Welcome to part one of our presentation on the implications for medical practices of the Patient Protection and Affordable Care Act. In this series, we're going to review some of the major provisions of the ACA, how they affect various components of our healthcare system, and especially how they affect medical practices. In part one, we will discuss some of the major provisions and the timelines applicable to those provisions. My name is Jim Hook, and I'm the Director of Consulting Services at the Fox Group. Our healthcare system is a little bit like the sleeping polar bear who is being awakened in a most disruptive fashion. And as we have seen, when the healthcare system is awakened, it is sometimes grouchy. In this part of our presentation, we'll describe the general timelines of the ACA and try to understand its major provisions as they affect patients, businesses, non-government payers, and medical practices. As you've probably heard, the ACA is a far-reaching piece of legislation affecting most everything that happens in our healthcare system. In particular, for medical practices, there are provisions which will affect payments for new patient benefits, significant changes in Medicare and Medicaid reimbursement, new self-referral notifications to be given to patients, new self-disclosure provisions for Stark violations, and new limits on physician-owned hospitals. Other provisions cover value-based payment models and pilot programs, new physicians affecting accountable care organizations, new provisions affecting PQRI incentive payments, and many other provisions, some affecting compliance and others affecting long-term care facilities. The Affordable Care Act was signed into law by President Obama on March 10, 2010. It was designed to make substantial changes in healthcare financing, healthcare delivery, and healthcare quality. Some observers have described the Affordable Care Act as unwieldy and unworkable. There is no doubt it is a complicated piece of legislation with complicated regulations to implement it. But many laws and regulations seem complicated until they are implemented and the pieces start to fit together. We should note that credit for this graphic goes to PA Consulting Group, who originally produced it for the Department of Defense to show another complicated situation. Even though it is not a factual representation of the ACA and the relationships created by it, it does remind us of the tendrils that the ACA involves, and besides, it's cool to look at. The Affordable Care Act affects everyone who uses, provides, finances, or regulates health insurance and health care in this country. The promise of the ACA is twofold. First, it is to expand coverage to 30 million of the 46 million people in the United States who do not have health insurance coverage. Second, it's designed to bend the cost curve, to moderate the share of GDP devoted to healthcare in the U.S. That share has risen to almost 15% as of 2008, and although that share is not rising as quickly, it is still much more than other developed countries around the world. There was a great debate about the constitutionality of the ACA, but in 2012 the Supreme Court upheld most of its provisions, including the individual mandate provision. They decided the mandate can be imposed under the taxing power of the Congress in the Constitution, the same provision that justified the original Social Security legislation. However, the provisions for penalizing states who did not implement the Medicaid expansion provisions of the ACA were struck down. States can opt not to expand their Medicaid programs to cover more residents without being penalized by the federal government. Implementation may be uneven because 25 states have declined to set up the state insurance exchanges called for in the legislation. This means the federal government will set up insurance exchanges in those states in order to carry out the law. The law requires funding from Congress, especially to administer sections which states decline to act on. So continued debate on implementing the law will undoubtedly take place. This map shows the states which have declared a state-based exchange in blue, those who are planning for a partnership exchange in light blue, and those states where no state exchanges are being set up, and residents will obtain coverage through a federally run exchange in the state. Some provisions of the ACA have already begun to be put into effect. For instance, in 2010, there were several important provisions affecting individuals and their coverage. Young adults could remain on their parents' health insurance plan until age 26. There was a $250 rebate to seniors who hit the prescription drug donut hole. The donut hole is the point in coverage when seniors must begin paying 100% of their prescription costs. After more prescription drug expense, seniors could get the benefit of 100% coverage for outpatient prescriptions. This donut hole provision was included in the original Medicare Part D legislation in order to reduce the cost. The provisions forbidding denial of coverage to children with pre-existing conditions and eliminating lifetime benefits on coverage also went into effect in 2010. There are no copayments for certain preventive services and new tools to fight healthcare fraud. And businesses became eligible for tax credits for providing coverage to their employees. In 2011, new benefits began to be added. There was new funding for community health centers and other public health programs. Prescription drug discounts for seniors in the donut hole were added. A new to Medicare and annual wellness visits for seniors became available. There was coverage of preventive services such as smoking cessation and free disease screening. And there's a limitation on the administrative expenses for health plans. This provision resulted in premium rebates to people whose plans spent more than 15% of their premium revenue on administrative services in 2011. These rebates were paid in the summer of 2012. And there's a new independent payment advisory board to advise the Secretary of Health and Human Services on payment aspects of the regulations. In 2012, there were provisions that mostly affected administrative activities. There were additional rules governing accountable care organizations that went into effect. There were rules for electronic interactions with and among health plans that were standardized. And a pilot program for value-based purchasing for hospital services was initiated. In 2013, there were several provisions which will affect payments for providers as well as benefits for patients. First, there's a new funding for preventive care for Medicaid patients. This care has been cut back in several states due to budget constraints at the state level. Primary care physicians who will be seeing Medicaid patients will now be paid Medicare rates for the services. Medicare rates will also apply to other physicians, such as surgeons, who are practicing in health physician shortage areas. And there will be pilot programs where payments for Medicare patients who are hospitalized are bundled. This means that hospitals, physicians, and other providers who provide an episode of care will be paid a single combined amount. They will then have to divide up the payment among themselves. In 2014, several of the most important provisions will go into effect. First, insurance exchanges designed to provide affordable coverage for businesses and individuals are due to be set up and operating. As mentioned earlier, the federal government will be responsible for setting up these exchanges in around 25 states. It is expected that coverage available through the exchanges will be less costly, especially for individuals, compared to the rates they can obtain on their own. Secondly, the individual mandate to have coverage goes into effect. There are various income thresholds that will apply to help make coverage more affordable through supplemental payments from the government. There are also penalties, starting out very low for individuals and families who do not obtain coverage either independently or through employment. There is expanded Medicaid coverage for individuals and families below 133% of the poverty level. Unfortunately, several states have announced that they will not participate in the expanded Medicaid coverage for their residents. There will also be tax credits available for those individuals who are not otherwise eligible for subsidies for coverage. And there are other changes going into effect in 2014. The annual limits on coverage for an individual are eliminated. This means that people purchasing a qualified plan cannot run out of coverage in their lifetime. There can no longer be discrimination based on pre-existing conditions or gender in determining coverage or premiums for qualified plans. and there are increased tax credits to small businesses who are providing coverage to employees. In 2015, the final provisions of the Affordable Care Act will go into effect. The main provisions for that year are new physician payment models that are supposed to be based upon the value of services instead of simply the volume of services provided. There are many excellent online resources to find out more about the provisions of the Affordable Care Act, including the timelines, the individual and business mandates, and the requirements on payers. Here's a partial list. This has been part 1 of our presentation on the implications for medical practices of the Patient Protection and Affordable Care Act. In the next installment of the series, we are going to review some of the major provisions of the ACA as they affect individuals, businesses, and payers. The Fox Group, providing excellence in consulting and implementation since 1989.